Innovation to me is driven by pain points, right? What drives innovation is what we're struggling with right now. And I think the major pain points in GI, healthcare across the system of GI specifically, access, cost, and patient satisfaction. I think those are the three major pain points. The easy answer there, artificial intelligence will have to be part of your practice. I believe in the next 3 to 5 years, if you go for an endoscopic test and artificial intelligence is not part of that, then you're likely missing out on that part of the test as a patient. I think disruption in GI will happen. You have to have change, you have to have evolution, but you have to break barriers. In order to change, you have to disrupt.
Dr. Neil Parikh, very warm welcome to the Scope Forward show. You're the chair of GI Alliance Innovation Committee, Chief Innovation Officer at Connecticut GI and Chief of GI at Hartford Hospital. I'm so thrilled to have you. I know we've been trying to schedule this for a while, but now we are here, and a very, very warm welcome once again.
Praveen, thank you for having me. I think we met a few years ago initially when your first book came out, I remember. So you've always been a few years ahead of the curve. So I'm honored to be here.
Excellent. Neil, there are a bunch of topics to cover, and I'm excited about many aspects of your work. But I want to start with your title. So now you have two titles that say innovation. So what do you do?
It's a great question. So I've been very fortunate that people who sit higher than me, the C-suites, the GI Alliance, and here locally in Connecticut, have found value in my buzzword innovation. Innovation to me stemmed early COVID, where we started to figure out what do we want to accomplish to create a better patient product? What can we do? Being a part of a large independent practice, Monday to Friday is pretty much the same. We take care of patients, we do procedures, we cover the hospital, we come in for a food impaction endoscopy. Okay. And then it repeats itself, which is good. We need that. But I started to wonder, what can we do for the future patient and for the practice as a whole? I came from a very academic background. Okay. So I was med school and residency at Mount Sinai in New York, very academic. Went to a fellowship at Yale as a research fellow, T32 fellow, working towards my K, eventually my R. And so I had a lot of that academic background. And I think that led me to believe that academics is where guidelines are written. Academics is where practice algorithms are defined. Academics are where you can create the future of GI patient care. I've now been in clinical practice and independent practice for 10 years. And while, of course, we need the role of academicians, we need the role of research. And what I do is not research. I clarify it. Innovation to me is not research. Innovation is feasibility pilots. But I believe large independent practices have the clinical volume and the clinical expertise to start having the conversation as to how can we start to affect guidelines? Can we start to show our experience and say, hey, this is our experience in this space. This is what we're doing. And we have the outcomes to show that this works. So innovation to me is the perfect playground to interact between industry, our corporate partners, our clinicians, our physicians who have the intellectual capital, as well as the academic side to see what is the best product we can do for our patients going forward.
Let's unpack this a little bit. When you consider innovation in gastroenterology in particular and healthcare at large, what are you seeing?
So I've said this before, and I think I said at our meeting a few weeks ago. Innovation to me is driven by pain points, right? What drives innovation is what we're struggling with right now. And I think the major pain points in GI, healthcare across the system of GI specifically, access, cost, and patient satisfaction. I think those are the three major pain points. And I think that's what's driving a lot of what we're trying to accomplish. How do we tackle access? As our patient population lives longer, we have more and more patients. COVID, for better or for worse, has reduced some of our workforce. How do we get all these patients in? Okay, cost. We want to be cost sensitive and provide high quality care. How do we use technology to provide higher quality care without being more expensive? And then patient satisfaction, right? Our consumers are our patients. We want them to leave not only feeling better, but feeling better about the process they were in.
Can you paint a map of innovation in GI? What are all the areas or avenues where innovation is occurring? For example, the microbiome or artificial intelligence or maybe robotics. Like, so from the lens that you're seeing and what you're examining, testing, can you present a map of innovation for gastroenterology?
Sure, let's start with artificial intelligence, which, as you know, is the most trendy innovation aspect or vertical in GI and healthcare in general. We're finding ways, and I'm going to almost lump artificial intelligence and precision medicine together because I think there is overlap there. So we are trying to find how can we implement AI in every facet of our clinical practice. Okay. So the roadmap could be the patient experience. So a patient walks into my office. Before they get to my office, I want AI involved in helping triage when and where the patient should be seen. I want AI involved in talking to the patient's insurance company before we're involved to determine where, if the patient needs a procedure, where can they get done. I want AI to already tell me when I'm walking to the patient's room which medications are going to be preferred. And why that's important, even before I see the patient, is all that leads to extra work that takes away from patient care. Okay. Not just extra work just for me, but for the staff of the office. And all the time we spend not focusing on the clinical aspect of the patient is time where we are taking away from what our original goal is, right? Our goal should be to have a consult with our patient and provide a clinical outcome or clinical treatment plan. What takes away from that? Well, the payer is saying, okay, well, these are the 4-tiered medications we choose. Or they're saying, you can't have this endoscopy here, you can have it there. I want to know all that before I get in with the patient. I don't want to waste time afterwards and then delay the patient's care. Okay, so that's back office. I want artificial intelligence in the consult room with me. Okay, the biggest example of this are the scribes we see, right? The AI scribes. We see this. We've tried a few different ones. We have preferences. Some work with our EMR, some don't. You want that scribe right there. Okay. When the patient leaves the visit, that AI scribe will already generate a summary. Why is this important? So I'm not one who brings a laptop into the patient room. Okay. A lot of my partners have no choice. Documentation is a big part of what we do. And if they don't bring the computer into the room, they won't be able to document fully the visit. AI can do that for us, right? AI can interpret the visit, document it, and have it ready to go. So we are focusing fully on that 30 minutes to the patient, fully. When the patient leaves your office, AI again has a role. That AI, like we said earlier, the back office end, can help us triage where the patient's next step is. We don't need to have a prior authorization team call and determine what we are going to be allowed to do, because that's a reality, right? I can have my clinical decision making, and then I got to figure out what am I actually allowed to do. Can I get a CAT scan? Do I need an ultrasound first? Can I do an endoscopy? Can I order this medication? Do I need to fail these 4 medications? All that delays patient care. Forget my burnout, my extra effort, my staff's extra effort. It delays patient care. And in 2025, I believe we have the artificial intelligence tools already available to completely streamline that to provide a better patient product. And then in gastroenterology, where else is AI involved? Well, next level, they come to our endoscopy center, right? We've seen this already with CADI, computer-aided detection of polyps, computer-aided diagnosis of polyps, already exists. But wait till we get into the upper GI space. Wait till we get into pancreas, the liver. A lot of what GI is image recognition, right? And artificial intelligence and large language models already exist to make it much easier for image recognition.
Very extensively, you've touched as far as AI is concerned. How about some other innovations? I'd like you to go further.
Yeah, so you mentioned the microbiome earlier, okay? I envision a future, and I think we're close. We're definitely closer than we were a few years ago, where I can have my patient who has refractory gut dysbiosis. What does that mean? An imbalance in gut flora, good and unhealthy bacteria in their gut is off. I envision a future where I can have that fully analyzed perfectly, not only analyzed, but then instructed on where and how they can, in their day-to-day living, their diet, their exercise, their lifestyle, start to supplement and enhance their gut flora in a positive direction. Okay. And there's companies that exist already do this. There have been GI mapping companies that check your microbiome for some time now. We're now going to a place where not only can we interpret that data, but then we can execute on that data. And I'm saying this with all due respect to the companies that are out there, because those companies have been needed as pioneers. We are finally getting to the point where we can execute on that data, execute on the microbiome data.
What role are gastroenterologists playing in that space?
I think we need to play a larger role. And I love what you do because physicians, we're built to be followers, right? We do so many things in our training that if you stop and question why we're doing it, we can't answer. We take multiple step exams, right? We do this mock now. We do ABIM this, ABIM this. We take all these things, and yes, a lot of it is necessary to get us to where we are clinically. But a lot we just do because part of our personality is to follow. Because of people like you and a lot of the guests you've on the show, we're learning that physicians also want to be part of the co-creation. Because we've been dealing with this. We have all these patients. We're part of it. We know what we'd like to see in a product or an assay or a test. And I think we are finally getting there. And some companies are realizing this and now starting to partner with physicians, with gastroenterologists to say, some of the microbiome data is probably not that helpful to me. I know what I think is helpful to me. I know what I can act on. Let's work together to create that.
I'm really excited about that space, and I'm looking to see how it's going to unfold in the future. I can be more direct, and so I don't see that much participation from the mainstream GI physician community, and they need to participate a lot more. Let's get back to the innovation map question, because there are other pieces that I'm curious to pick your brain on. Non-invasive tests. What's your take? Where is it and where's it going?
We absolutely need it, right? I would always talk, again, I'm trying to be careful what I should say, what I shouldn't say, and then I just go back to what I'm going to say, which is fully transparent. We have an access problem, right? We can't scope everybody, whether it's a colonoscopy and an endoscopy, we can't get to everybody. And we have a cost problem, right? So non-invasive tests are only strategy to get that next barrier, right? Get past that next frontier. And non-invasives, if done correctly, will help us truly triage who needs that next endoscopic evaluation. Even in best estimates, we don't need to get into details, but you look at the colon cancer screening space or esophageal cancer screening space, best estimates, 60% of who needs to be screened are being screened. You know why? There's only so many of us. There's only so many places you can go get a colonoscopy. So you need non-invasive to help triage those people who are the 40% that we're not catching. Which of those 40% need a colonoscopy? Absolutely need one. They needed one yesterday. They needed one 3 months ago. Those are people we can't miss. Colon cancer can be 100% prevented if you find a polyp. Okay? So if you're in Connecticut, where I am, or you're in the West Coast, you're in parts of the country, in parts of the Midwest where you have access to gastroenterologists, you can have this conversation. You talk to your GI and say, hey, what should I do? And what I tell them is, hey, you're in a part of the country where you have options. If you want to prevent cancer, there's only one way to prevent colon cancer. You got to find and remove a polyp. Okay? Done. That's a colonoscopy. If you want to just detect, if you want to just know yes or no, do you have colon cancer? You have multiple options. Now, say you are living in a place where you don't have a gastroenterologist nearby, and you're having this conversation with your primary care provider, and they say, okay, all right, we can get you in to see GI to have this conversation. It will take 6 to 12 months, but we'll get you there. That person should be on the conversation. Or we can just find out right now, what is your risk? What's your triage risk? Let's detect if you have cancer, yes or no. Do a non-invasive. Most of us will argue, unfortunately, if we detect cancer on a non-invasive, we already missed the boat, right? We already are a little late, but it's better to be there than to wait 1 more year or 2 more years when that patient's being found in the ER with rectal bleeding and now it's spread everywhere.
Any other aspect of innovation that you want to highlight?
Yeah, I mean, the other non-invasives that I've more recently come across are in the upper GI space, right? And this, again, it's the pain points, access costs. So payers are more and more reluctant to cover upper endoscopies for a variety of what they consider non-alarming indications. Acid reflux is silent. How can you tell me what's alarming or not alarming? Fine, you won't cover the endoscopy in everybody. But what if I come to you with criteria that say you have acid reflux, you're of this age, you have this, this, and this. And if you still don't cover endoscopy, I need a non-invasive option. And that's coming up more and more in the space, especially in Barrett's esophageal adenocarcinoma.
Neil, let's take a step back and watch all these innovations from a distance. So we talked about non-invasive tests, we talked about AI, we talked about the microbiome, a lot more. Like, so you can add robotics, you can add a whole bunch of other things that are going beyond GI, but healthcare in general. Now, when you look at all this at play today and put this on momentum, I call them exponential technologies, converge. When these technologies converge or these innovations converge, where do you see or how do you see it play out 5 years from now, even 10 years from now? What would day in the life of a gastroenterologist look like about a decade from now?
The easy answer there, artificial intelligence will have to be part of your practice. Okay. I believe in the next 3 to 5 years, if you go for an endoscopic test and artificial intelligence is not part of that, then you're likely missing out on that part of the test as a patient. I also am hopeful and foresee a future where we'll be able to do more point of care testing with these non-invasives or quick turnaround tests, whether that's in the office intestinal ultrasound or in the office quick blood testing right there. Get rid of that delay in care that we currently have. And that goes back again to access, right? So if I order a CAT scan, I am then relying on my local radiologist to be able to get the CAT scan in. Now, if they're delayed or there's a backlog there, again, we're delaying care. The more we can do in real time for the patient, which I believe the technology does exist, the better patient care we'll have. And I think that's how the future will be.
By the time that we get to this future, this holy grail, do you foresee a lot of disruption occurring in private practice GI particularly?
So I think disruption in GI will happen. And in order to change, you have to disrupt, right? That could be the title of your next book. You have to have change, you have to have evolution, but you have to break barriers. I like the word independent practice, but we'll take private practice, okay? I believe, and you can say I'm biased, but I believe independent practice is specifically positioned at the top of this innovation mountain because we are going to have the most clinicians, the largest patient volume to then help dictate what the future of GI care should be. I'll give you an example. As we start to better understand and better collect data on what's leading to better outcomes for our patients, we are at the GI Alliance 1,000 gastroenterologists. That leads to many, many patients. As we start to better understand how that data is being aggregated and find trends in the data, we can then use our industry partners and find new ideas and say, okay, well, this is a new test. Look at precision medicine. Let's take one lab count, one lab test. I'm going to make it up. We're going to call it Lab XYZ, not to violate any NDAs here. Lab XYZ. Lab XYZ has a 60% specificity, 60% sensitivity for, make this up, liver cancer. Okay. Now, if I can run Lab XYZ, which we collect anyway, on our pool of X amount of patients, I can then identify which patients are at risk. Then I can see what their outcome was, what their trajectory was. I can look backwards very easily with data and say, okay, this is what we should do, this is what we should have done, this is what we will do. And then I think with that, we'll be able to say, hey, you could do a randomized controlled trial, and you should. You could do your study with X amount of physicians at X university. But this is what we've done for the past 8 years. And this is what outcomes we have shown. And I think we have to blend that. So when you look at innovation and private practice, obviously in our situation, we're a large practice. We have an innovation committee. We have now physicians, gastroenterologists from across the country work together, piloting new ideas. So we will continue to be ahead of the curve, or want to be ahead of the curve, because we want to help guide what the future of GI looks like.
I'm going to ask a question on behalf of the gastroenterologists who might be looking at you, listening to you, and thinking, hey, I want to do what he does, but how does his practice make space for that? Because that's a classic problem. It's not that the physicians out there don't want to innovate, they just don't have time. And if they even create personally, the time to do this, there's a kind of compulsion within the system that we have created collectively as an industry right now to do more procedures. So how do you navigate that, and how is your week structured? How do you create the space and time for innovation? Or is it structured as part of your job?
So when you look at innovation is challenging because you're always trying to prove future value, whether it's to your CEO, your board, your partners. And as you may know, most of the things I do will fail, right? Most of the things we test and try are not going to be winners right away. That's part of what you have to go through in innovation. You have to try and fail things. So in order to get a position or to get what I was able to get, you have to have leaders in your organization who can look beyond the RVUs, look beyond the day-to-day and say, okay, Neil's going to bring value to our organization. It may not be value today, tomorrow. It may not be equivalent to him doing 4 colonoscopies or 20 endoscopies, but he's going to bring value to the organization by providing, ideally, a better roadmap for patient care in 6 months, 1 year, 5 years, 10 years. It has not been easy to create this position or to define this position, and it's constantly evolving. When I first started, again, I came from an academic place. I told my CEO and chairman here locally that I really wanted to be involved in education, work with the fellows. I didn't want to lose that academic aspect of my training. And that evolved with education. Okay, well, with education comes, we educate each other. We educate the partners. We educate our nursing staff. It wasn't just typical, and it was never just, conducting a lab research study. That evolved into an innovation because with education, I started developing more and more relationships with industry. Because you try to educate on a topic, well, industry has resources on the topic, okay? You can create your own resources, or you can ally with industry and use their resources. And I think that's what led to this innovation angle, where we start realizing, talking to some of the more forward-leaning companies, that they have ideas. They have resources behind the ideas, but they want direction. And what I can offer, flawed sometimes, right, sometimes wrong, is what I think the direction should be. And I think that has showed my local team and the GI Alliance nationally that there is value in being part of that conversation, right? Going back to the academic place. So I always quote, or people have quoted, like ADR. ADR is like our holy grail, right? Every gastroenterologist goes by ADR. I don't want to misquote this, but I believe ADR, that study, was only 4 or 5 gastroenterologists. Okay. So when I sit at our GIA meetings and I say, hey, we are 1,000 gastroenterologists, we should be able to determine what is an optimal benchmark. And we would propose it. There's no hubris here. You need academic places to validate, double check what we're doing, but we're in a position where we can propose what to do. And when I sit there very enthusiastically, very passionately tell our national board, our C-suite, our local board, this is what I envision we can do, be part of this conversation, I think I convinced enough people. So you asked me what my day-to-day looks like. I'm still very clinical. I'm 95% clinical. So a lot of innovation happens, when I find time to innovate. Innovation, often they're meetings. I'm very lucky to have 8 gastroenterologists across the country. We meet every quarter. We meet at 9:30 at night Eastern time, and we talk till about midnight, a little past midnight. And we talk just what is exciting them in GI, what they look forward to GI, and what's not working in GI. And then we look around who are already trying to solve those problems. So right now, AI agents is something that I'm really trying to learn a lot about. I've yet to find, and they probably exist, I just don't know. I've yet to find an AI agent that I think would do everything that I want for my practice. I want just one company. I want one agent. I want somebody to answer my bowel prep questions, some agent to be available when they call the front desk. I want it to be all that. I want it to be a RAG model where I can give it the textbook. I can teach it what to say. So I use various platforms. I talk to my connections. I have friends in VC. I'm like, hey, who are you hearing about? And then we talk. And then it's great. It's just a conversation with a CEO who's much smarter than me in AI, who says, this is what I can or cannot do. And I say, this is what I would like to do or not do. And can we create something together?
Very interesting. And we can talk more about that. And in fact, a whole podcast can be
there you go. Yeah.
based on that. Let me get back to the innovation and the job question. What advice would you have for somebody, looking to do what you do?
You want to be in a supported environment. And I find, and this is not an all-encompassing answer, but a larger practice will likely give you more wiggle room to do what you love to do, whether that's ESD or endobariatrics. Smaller practices are really just trying to keep up with their patient volume and do colonoscopies for every 45-year-old in their practice. I also feel, so when I graduated from Sinai, that year was a year they combined second years and third year residents into one application cycle. So I was one of 16 people who went into GI that my year from Mount Sinai in New York. I talked to my co-residents. I think academics is great if you have a specific focus and that's what you want to do. And you want to get your R, you want to have that lab, and you want to pursue that true bench research. I think a large independent practice, if you're still trying to figure your way out, figure out what you want to do, because this didn't come in that. I didn't leave fellowship and say, hey, I want to be innovation officer 10 years ago. I think a large practice with supportive leadership can help navigate that for you. And then you create your path.
Let's switch gears. Why did you start the Gut Doctor podcast?
So like I said, I was in charge of education for our group. All right. And in Connecticut, when COVID happened, we were over 80 gastroenterologists and I think 45 advanced practice providers. At that point, my job as education chair was to make sure we were all up to date with our knowledge in effort to have the same standard quality of care across Connecticut. But COVID happens. No more grand rounds, no journal clubs. A lot of what we relied on traditionally to educate ourselves went out the window. If you can't tell, I really like to talk. And at that point, I was driving once a week, an hour to this more remote hospital. And I loved podcasts. I did a lot of history podcasts, which was my interest. And I was like, well, this would be a great forum. So I started by recording my partners actually at Connecticut GI, my Barrett's expert, my ESD expert, my EndoFlip expert. And I said, tell me about what you do, why you do it, which patient should get that done, and what is the downside, risks, benefits, indications, and clinical outcomes. And we started recording. and we put it on Google or yeah, Google and Apple initially. And as you know, once you put it there, you can't really control your audience. So within a few months, we started realizing our marketing team locally was like, hey, this is being picked up in a variety of places. I never marketed it. I never had a budget to market anything, and I didn't have the time. I still to this day record usually 9 p.m. at night, which is the only time my house is quiet enough for me to record in my wife's makeshift office. It seems to be doing okay. That started basically as listeners started to chime in. I have had patients now come see me from different parts of the country because they heard a podcast on coming off of a PPI, for example. And now it's really played in nicely with innovation because as I talk to startups, I say, hey, you have this idea. Let's talk about the idea. Do you want to be on the show and talk about the idea? Startups like it. It's great marketing for them, great way to get their message across. And I learn a ton. It's a great way to CME. It's a great way to network. But it truly started just as an education.
What have you learned, from all these conversations? If you have to, let's say, summarize in 3 bullets, what would stand out for you?
I've learned the most that I've learned has been in what I call my food as medicine series that we were talking about offline. The non-traditional therapies in the GI space. So from purely learning that I've been able to take into my clinical practice, it's been from there. It's really learning, how does apple cider vinegar really fit in? Where is the interaction with coffee and the gut? We talked about Reiki earlier, and you said both your parents are Reiki. To me, Reiki was just okay. Yeah, I've heard of Reiki. I had no idea what it was, and then I didn't know how I could potentially implement it in my clinical practice. So that's been extremely powerful. So that's probably the most true clinical pearls have been in that series. Other than that, just talking. So I have a GI 101 series where I talk to fellows about bread and butter GI topics. That to me has been great too, because it's a refresher course for me. Last time I read up on diverticulitis probably was 15 years ago. So when I have a fellow, about a year ago now, tell me about diverticulitis and the latest guidelines on it, or H. pylori, I mean, that is the best way to educate myself because I have somebody who's in it right now, right? In training, learning the latest guidelines, the latest clinical pearls, and now teaching that to me. And the last bullet I would say goes back to innovation, with the startups, the companies, learning different roles, what people do, talking to CEOs of companies and talking about their entrepreneurship, because I think that is still, as a physician, like you said, we have physicians who want to be entrepreneurs, but we don't provide those physicians the tools to become entrepreneurs, right? We get no training on this, which is fair, right? Clinical training is already 3 years, clinical GI fellowship. That is just the tip of the iceberg. Clinically, we need to know. But we don't learn anything about patent lawyers. We learn nothing about how to get funding, seed rounds, Series A, Series B, all this stuff you can learn from people. There are people out there who can teach you, and the podcast has been a forum for me.
Very interesting. I want to touch on your first takeaway, which is food as medicine and these alternate therapy within GI. Many physicians that I know would hesitate to talk about all of this. One, because there's no familiarity. But two, there's also hesitation, like, why go there? My sense is physicians are afraid of being ridiculed by their peers and risk being called as unscientific because now you're going to all these woo-woo topics and we don't learn about them in medical school. And the evidence is also not very obvious. It's not like the mainstream evidence. I was surprised to see your posts on LinkedIn about these different podcasts, but you didn't hesitate to go there. So I'm just curious to know what you think about it. And is it a curiosity to learn? And how did you cross over this threshold? I'm sure it must have occurred to you as well. But how did you cross this threshold that, hey, this is important for the patient, so I'm going to do it anyways?
Praveen, I think that's the most important point right there. My decision to go and pursue and even use alternative therapies was purely patient driven. The patients are our consumers, right? This is what they want to hear about. Okay. Most patients are not looking for a quick fix or a prescription medication. My job as a gastroenterologist is to make sure, in usually that first visit, that I say about that 30% of people who need a prescription, okay, they need traditional therapy. And then the 70% who can really have time to figure out their diet, their lifestyle, the alternative therapies, then hone in on those people. But it was truly driven by patients kept asking me, oh, well, I tried this supplement. I tried that. So you have two choices there. One, you can be like, okay, well, go talk to your integrative physician. Go talk to your naturopath. Close the door. Or you can say, okay, what have you tried? What has worked? And I often tell patients, if that worked, tell me what works so that I can tell the next patient, hey, this worked for my other patient. The reason us as traditional physicians, gastroenterologists, providers are hesitant is what you mentioned. We don't get much training on this. In fact, we get no training on this. And then there are no randomized controlled trials. The holy grail of what we have spent over 15 years in medical training are randomized controlled trials. It's really hard to find a randomized controlled trial on yogurt and inflammatory bowel disease. There is one out there. It's 40 patients, RCT. In some people, yogurt does help. I'm a huge believer in yogurt, okay? But we don't have the data. Cynically, I believe we don't have the data because who's going to pay for that data? Okay? I grew up in a household where my mom made yogurt in the room next to us. Okay, you probably did the same thing. Okay, I'm going to go ahead and just say that. And I remember we'd make yogurt in the corner. It was like you took something, you put it in there. It was called man run, and you covered it in a thing, and it had to be a certain temperature. Okay, you know exactly what I'm talking about. And then the next day we would have that yogurt, and it was delicious. Who's going to pay for that RCT? Who's going to benefit? Which company will benefit? Nobody. Is it the dairy industry? Maybe. That's your best bet, is to say, hey, dairy industry in America, I have a new indication for one of your primary products, milk and yogurt. Do the study. But we don't have that, right? And so when we don't have RCTs, we get nervous, we get anxious. And that's fair because we don't know who's going to work for, who's not going to work for. But if it's a low risk intervention, and I believe yogurt for the most, and there are some downsides to yogurt too. I have a podcast on it, so we can go over that at some point. But there are some downsides. For the most part, it's a low risk intervention. I think it's worth trying. And I have found enough time and evidence of these alternate therapies that work. Okay. The second reason that for me, it goes back to just growing up. I think I remember we used to go to India the summers, 110 degrees outside. Okay. Where I used to go to India, there was no air conditioning. Unless you went to a movie theater and pay for the AC ticket from 12 to 3, there was no air conditioning. I still remember my grandmother, and this is going to sound crazy, but taking onions. And once I think she said we should keep onions around our neck because it'll help hydrate us. And I don't know if that's true or not. And anybody listening, please don't put onions around your neck for dehydration. I don't know if that's valid. I should ask open evidence that question. But I think we were always exposed to this, right? Exposed to alternative therapies. And so it made it easier for someone like me to incorporate that in my practice. But really, it was patient driven. Patients want this. And I will say there as well, if you're going to start this alternative therapy as part of your GI practice, get to know a naturopath you trust. Okay. I've been very lucky. There's a few naturopaths, there's naturopathic practices in my area because you're not going to know all the supplements. It's really hard to keep track of all the supplements. And so if you can work with a naturopath, you can really provide the best teamwork for that patient.
What would you tell a gastroenterologist who's pretty much dismissive of these therapies, including food? Like, so because he or she has not been trained, and a lot of patients experience this, the physicians dismiss them and they say, oh no, don't go there.
And I tell my partners, my younger partners are so willing to listen to me. I say, your job is to identify the patients who absolutely need medication, who absolutely need a test, who absolutely need an endoscopy. Okay, identify those. We don't want to miss those patients, right? There are some people with inflammatory bowel disease, many of them, that absolutely need therapy. They're going to need an injection, an infusion. Okay, they're not going to get better. It doesn't matter how much food changes they make, no matter how much turmeric you give them. their mucosal lining will not improve. All right. I tell my partners, we have the expertise to determine who those people are. Once you've identified those, you put them in a separate category. Okay. If those patients ask you, hey, I want to try dietary change alone, you don't dismiss them, but you tell them, hey, we can do that, but we can only do this for a defined period of time. Because in my experience, and despite me being open to alternative therapies, your disease state will not respond. Patients appreciate that. I don't say don't try at all. I say, hey, we can try it, but just remember, things may get worse by trying it, but I'm willing to work with you in trying it. And then they may come back to you and be like, Dr. Parikh, you were right. That didn't work. What are my more traditional options? That's what I tell my partners too. I think once we can identify those who will not improve with traditional or non-traditional therapies, we put them in a separate bucket, and then we try to. I really believe 60 to 70% of patients with GI disease, GI distress, we have time to work on their diet, what they're eating, their lifestyle. If you talk to one of my patients, I prescribe adult coloring books often. Just spend 15 minutes, put your phone away, and just draw. I wish I've gotten better. We were talking, as I've gotten older, my sleep is not as great as it used to be. And I blame my phone for most things that are not good with my day-to-day mental hygiene. And so my daughter made a phone box for me. So every day that I'm not on call, to specify when I'm not on call, my daughter takes my phone, puts it in a phone box, and I don't get my phone again until they're in bed. And just that mental reset, that reduction of global stress levels, I think helps your gut. Goes back to the gut-brain axis. So if you can do that for 15 minutes a day with a coloring book, a walk, people say meditation, yoga, all those things sound great. For me, I've never been one who can do them. I think my mind races too much to meditate. But for those who can, that's great. For those who can't, just color.
Awesome. What do we know about the gut-brain axis since you mentioned it?
We know it's there. Okay. We know that the gut-brain axis directly influences your gut flora, your microbiome, your microbial composition. There are definitely physicians, scientists out there who have pursued this even further and can give you more scientific analysis of how that works. From my sense, from one who doesn't do research in this field, I tell my patients, hey, if you're stressed, you're happy, you're sad, you're anxious, all those will affect your gut and your GI symptoms. So I can only get you so much better with targeting GI alone until we also target the mental well-being. We've seen, and we're very lucky that we have in our practice, GI psychologists who can do cognitive behavioral therapy, work on exactly this axis. Can we reduce the hyperactivity of this axis, or can we even break that cycle? I'm worried about my bowel movement. My bowel movement gets worse. I worry more about it. It's a cycle that goes and goes and goes. And unfortunately, a lot of irritable bowel syndrome is just the anxiety component, and that does make us go to the bathroom more often. And now we're like, oh my God, I'm on an airplane for 4 hours where I don't really like the bathroom near me. I'm feeling more crampy. I feel that urge. I feel bloated. So I don't think it's fair for me to tell you the specific scientifics behind a gut-brain axis, except for the fact that I'm a huge believer in that axis. And the more we can tackle both the gut and the brain aspect, the better our GI patient does.
I'm so glad to hear all these various viewpoints, Neil. I have a question brewing. So recently, I had a conversation with a gastroenterologist, and he was sharing about his practice and the younger physicians and all of that. And he happened to share that, look, nobody wants to see patients. So I thought I, heard it wrong. So I was trying to understand. I said, what do you mean nobody wants to see patients? So he said, no, everyone wants to do just procedures. So I said, that's interesting. And I asked again, I said, they don't want to see, no, because they just want to spend all the time in the endoscopy room and do procedures because that's what generates volumes and the RVUs and the money and all of that. So I said, okay, it's so that's one angle, I want to put it out there, right? So that's one data point. The other data point is the AI and everything else, which is coming,
Yeah.
disrupting the procedures. And if you've read my work or like listened to some of the things that I've said, of course, I take it to the very edge. People at least take note, pay attention, and all of that is, yeah, there's a real risk of disrupting mainstream procedural gastroenterology. The field has an identity with doing procedures. Like, so because if I don't do it, then who am I? If I don't do endoscopies, then that's my identity. Like, so then who am I? Like, right? So you have that going, but not everybody is an advanced endoscopist. And the mainstream is likely to get disrupted. Like, so with I know a startup that's building a colonoscopy robot. So it's going to go in. I've seen certain things like, so it's going to go and do a few things. You couple that with AI, so you have disruption on the horizon. And then the third angle of innovation, which you're representing and are the bulk of our conversation today, nobody's creating really the time and space for it. And very interestingly, you are viewing innovation also from the lens of patients, your consumers. And if they're going in the direction of food as medicine, you're willing to go there. So when you put all this together, I've triangulated, this information. And if you can be very direct, like, I'd I'd appreciate that. Do you see a time that like the mainstream gastroenterologist who is so occupied inside of the endoscopy room right now, maybe for good reason, learning and practicing or capitalizing on a skill that is very likely to get disrupted and not creating the space and time to move in a new direction, which does take space and time to learn? I see a big problem. What do you see?
I'm always direct. So if you ask 9 out of 10 gastroenterologists, 9 out of 10 physicians, why they structure their week or the day the way they do, look at the same answer. Okay. Most of us, I would say myself, all my partners, what we enjoy more than anything else is the physician patient interaction, right? That's why we went into medicine. It's why we didn't go into other fields that are not patient facing. Okay. In a vacuum, the most joy I get is sitting in my office consultation, talking to the patients. And I was actually was in office yesterday. I said, one patient, she's like, I'm so sorry. I came here when I was feeling better. I almost wasted your time. I'm like, no, actually, that's the best part. Like every so often you get a win, right? You see a patient who was suffering a few years ago and now is much better. In GI, extremely rewarding because most of my patients have irritable bowel syndrome. Okay. Most of my patients are bloated. Most of my patients have diarrhea that's waking them up at night or interrupting their day to day. So when you see that, and those are GI is interesting, right? Because people are embarrassed to talk about that because, like, well, it's not like it's going to kill me, but it's really, I'm like, no, it's annoying, right? So when you change that patient's trajectory where they're no longer bloated all day, they're no longer leaving their boardroom meeting 4 times in a 1 hour meeting to use the bathroom. And as you know, you get up, everyone watches you, right? They watch you, they pretend not to watch you, they all watch you. That is the most rewarding aspect. Okay. And even the physicians you've talked to who said, I think the quote is gastroenterologists don't want to see patients. I would challenge that. I think most gastroenterologists, if you did an anonymous survey, would say they love seeing patients. So why? Why has this evolution happened? It's the way the system has created a reimbursement model. Okay. And it really depends on where you practice. Again, I feel very fortunate where I practice, without getting into the details, we are being rewarded for our patient interaction time, our patient facing visits, whether it's endoscopy or in the office, as much as we are just generating procedures. Okay. The system needs to evolve to that too. And we're not perfect. We can even get better because you're right. Ideally, our clinical skill set, the 15 years of medicine we've done, is not fully, how do I say it? It's not just meant to be in a 35-minute procedure. It's about going over the differential, listening to the patient's story, and coming up with that treatment plan. Okay. And again, I think as our global reimbursement compensation model, I've been pushing for this thing called academic RVU for forever. Okay. And maybe it's for academic or non-clinical RVU. So to give physicians credit in our traditional RVU system for non-procedural work, you are providing better enhancement for the patient experience. You should get credit for that. I hope at some point we do that, because you're right. If we don't do that, if we go down this path where we will only pay you for doing a procedure, okay, then we run the risk of losing more and more gastroenterologists. I don't think we're going to go that way. I think we're going to realize that, hey, as a physician, as a GI APP, our value is in our conversation with our patients, okay? Our patients come to see us because they want to talk to us. When we're in the endoscopy suite, the patient is asleep. There's no interaction anymore, okay? And I think as we globally change the way we reimburse the system, you're going to see less of this pull. Because I don't think physicians don't want to see patients. I think physicians are being left with no choice but to limit the time they see patients. Look at primary care. My dad's a primary care physician. He has been an independent primary care doctor for over 40 years. Okay. He still sees quite a few patients. He can't type fast. So you know what? It works for him. His patients love him because he just goes there and talks to his patients. He then spends Saturday and Sunday, all Sunday, writing the notes from the conversation. Okay. AI will help a little bit. But if we started to give more credit to the conversation than just the technical aspect of our job, you will notice that most physicians really do value the interaction with the patient.
So glad to have these reflections. And I know we could go on. In the interest of this recording and the podcast, are there any final comments, Neil, that you think will be helpful for the trajectory that we've taken listeners, in this conversation?
I guess my take home to your listeners, if there are young physicians and trainees, is to really spend time figure out what you want to do. I tell every fellow, you're the asset now, okay? We spend most of medical school residency lying to our future bosses what they want to hear. Yes, I want to do interventional endoscopy. I want to do EUS drainage of so and so and so that. You're now a fellow, you're looking for a job. Be honest with yourself and be honest with your future boss. Because if you are honest and spend time figuring out what you want to do, you can really create a path that's rewarding. Okay? For the patients listening, I will really, truly believe that with artificial intelligence and clinical training, we will be able to provide the best product for you. Okay? And I believe that over time, we're going to keep refining and honing in on what that product really means for the patient to create the most accessible, cost-effective patient experience.
On that note, thank you very much, Neil, for coming on the Scope Forward show. And I'm looking forward to continuing our conversation again in the future.
For me, really appreciate it. Thanks so much for all that you do.